beautiful countries in the world, India and Australia. This is eCritCare Podcast about evidence-based critical care medicine, helping you to save lives. Here are thoughts on controversies in critical care. And now, here are your hosts, Dr. Swapnil Pawar from Sydney and Dr. Jose Checco from India.
Welcome to eCritCare Podcast. This is our episode number 88, and also this is our first episode of year 2022. So first of all, to all listeners, wish you a very happy and healthy 2022. And Dr. Checco, welcome to another season of our podcast, and also wish you a happy new year.
Thanks, Swapnil. Happy New Year to you, and Happy New Year to all our listeners who have been around all through the year.
Yeah, so what a start of the year 2022. Obviously, everybody was hoping to start 2022 with relatively fresh breath, but we have started in 2022 another wave of COVID-19 with this newly diagnosed variant called as Omicron. Now, this Omicron variant has shaken the entire world now, and everybody seems to be quite concerned as number of cases are going up and up in every single part of the world. And in today's podcast, we are going to discuss about what are the potential challenges that this variant has brought to us and what are some of the facts that are emerging from the pattern that we have seen so far. So first of all, a little bit about this variant. The first sequenced Omicron case was reported from Botswana on November 11, 2021. A few days later, another sequence case was reported from Hong Kong in a traveler from South Africa. And after that, several sequences from South Africa were followed, and the new variant was labeled as Omicron variant. Now, this variant was associated with H gene target failure with a specific PCR assay because a 6970 del deletion, similar to that was observed in Alpha variant. Now, the earliest known case of Omicron in South Africa was a patient diagnosed with COVID-19 on November 9, 2021. Although it is probable that there were many unidentified cases in several countries across the world before then. Now, the reason why everybody got worried about this variant is because increased transmissibility of this variant. So just to give a bit of perspective about in South Africa, the mean number of COVID-19 cases were 280 per day in a week before the detection of Omicron. But after the week it was detected in South Africa, the cases number risen to 800 cases per day. What we have seen so far, and this is classified now as a fourth wave of COVID-19 pandemic, which was started back in December 2019. In the first wave with Alpha variant, the doubling time was around 1 to 3 days. But obviously the symptoms were minor and there were not a lot of patients who died with that wave. In the second wave, which is a beta wave, the doubling time was around 1 to 7 days. While the third wave, where the Delta variant was identified and which was obviously considered to be more fatal variant so far, had a doubling time of around 1 to 5 days. While with the Omicron variant, in the fourth wave, the doubling time is 1 to 2 days. And it seems that it transmits very quickly to multiple people in the population. And that obviously led to a significant increase in number of cases across the world. Just to give a perspective, in Australia, in Sydney at the moment, the number of cases have increased so much. And obviously that led to a significant increase in hospitalization. Although what we are seeing that the proportion of patients who are admitting to intensive care is not the same as the previous wave, what we've seen with the Delta variant. So the preliminary concern with Omicron variant is its increased transmissibility. Obviously, this is on the background of the COVID-19 pandemic, which has caused a lot of anger and frustration amongst both healthcare workers and also in the community due to the widespread negative impacts on the social, mental, and economic well-being. So in today's podcast, we are going to dive deeper into what are the kind of specific features of this Omicron variant. But also then towards the later part of the podcast, we'll talk about what are the challenges that we are going to face as a healthcare with this wave. So Dr. Checco, first of all, can you tell us about why the transmissibility of this variant is so high and why we are seeing such an increased number of cases?
It's true. It is highly transmissible from what we've seen so far. You described it the way it's been happening in Sydney, pretty much similar to what we see in India as well. We have roughly about 200,000 cases per day. In fact, this number has gone up so much in the last few days that it's almost like mind-boggling, and we've almost like lost count of the number of cases identified per day. Of course, gene sequencing and specific diagnosis is done on very few of these patients due to practical reasons. But one would assume that most of these patients probably have Omicron. And when it comes to the actual number of Omicron cases, we have, I think, roughly about 4,000 cases in India at the moment who are diagnosed with Omicron. Of course, the actual numbers are likely to be much larger. And you asked about the transmissibility. Yes, it is highly transmissible. And when you talk about transmissibility, you go by the R0 value, which denotes the average number of individuals who will contract the disease from an infected person. And with the original strain of the SARS-CoV-2 virus, the R0 was 2.5, which means that an infected person is likely to transmit the disease to 2.5 people. For the Delta variant, of course, it was much higher, and it was around 7. So one person could transmit it to 7 people. And the R0 value for Omicron could be, they say, as high as 10. So that is extremely concerning. And one of the reasons why it is so transmissible is probably because it colonizes in the nose, doesn't go down much down the airways into the lung. It stays within the nose, and from there, it aerosolizes, and through droplets, it gets transmitted to others fairly quickly. So that's the purported mechanism, at least, as to the mechanism behind the very high transmissibility that we see with Omicron.
Thanks, Dr. Checker. So, yeah, and that's exactly what the pattern has been observed so far across the world. Maybe it's South Africa, maybe it's states, where maybe it's Australia or subcontinent in India, that once you get this variant into your country, the number of cases goes up exponentially, and then it becomes a significant problem for healthcare to tackle. First of all, testing that large number of population, then also deal with the hospital admissions. Now, the second important concern that has been raised with this variant is the potential for immune escape. And just to kind of understand what this immune escape is, especially after the COVID-19 vaccine development, which was considered to be a breakthrough in the middle of the pandemic last year, most of the countries emphasized on getting majority of the population vaccinated. Especially in Australia, we did really, really well, where we achieved almost 90 to 95% double vaccination in some of the states. And everybody thought that if we can get that 80% double vaccination mark, then we probably would be pretty good to deal with the whole pandemic. And clearly the vaccination has shown its impact in terms of reducing the number of cases, reducing the number of hospitalization, and reducing the number of patient deaths. However, with Omicron, despite some of the countries or some of the states being triple vaccinated, we are still seeing the large number of increased infection in the community. So can you please tell us about this potential for immune escape with this new variant?
Yeah, Swapnil, cross-neutralization against Omicron from previous non-Omicron infection appears to be very low, because there have been several instances wherein people got infected with Omicron after a previous infection with the Delta or some other strain. So from the information available so far, there appears to be a high incidence of infection with Omicron in individuals who were previously infected with other variants. Most COVID-19 vaccines have been effective in the prevention of severe disease, hospitalization, and death with the previous variants. So the vaccines work not only by generation of antibodies, but also through their T-cell dependent immune responses. So even if you have antibody levels, it may not actually mean that you're immune. And also, on the other hand, even if your antibody levels are low, you may still have T-cell immunity, which might protect you. Of concern is the fact that even in the UK, like you mentioned with Australia, wherein they have almost 70% double vaccination, and 90% of individuals who have antibodies in them, the caseload has been just spiraling upwards in the last several weeks. to phenomenally high numbers. And from what we've seen so far, protection against Omicron may be just 10% after 6 months of a double dose vaccination, compared with 40% for Delta. So the actual level of immunity against Omicron may be much, much lower compared to Delta, even after 2 doses. The T cell response is against the whole spike protein, and hence vaccines that induce a robust T cell response may retain efficacy against Omicron. But it's hard to know as to, at this point of time, which vaccines are likely to be effective.
Thanks, Dr. Chacko. So obviously this variant has clearly challenged the myth that a lot of people initially thought that once I get infected with COVID-19, I'm immune for at least next 6 months to 1 year, and I don't need to be worried anymore because I got this protective immunity from the previous infection. And clearly that's not the case with Omicron. And one of the features of Omicron is that it has got 30 different mutations identified so far. So obviously this virus has learned clearly how to escape to all the immune mechanisms that has been developed due to the previous infection or due to the vaccination in the past. So that has obviously been a major concern. There has been some signal about some of the vaccines are effective more than some other vaccines. And as you said, we'll talk about that in a minute. But before we dive into some of the treatment aspects, the other concern and other area of uncertainty is around the severity of the illness due to Omicron. And a lot of politicians and a lot of healthcare bodies initially neglected this variant due to the message that came across that, oh, this variant is highly transmissible, but obviously less severe. So we don't need to be worried about it. It's almost like another common cold virus where a lot of people might get sick for a day or two, but they obviously don't need hospitalization or they are not going to come to intensive care. So what's the literature available so far on the severity of this variant?
We have some data today to indicate that indeed Omicron might not be as severe as we saw with, say, Delta. And there are some reports from across the world. Initial reports from England, Scotland, and South Africa suggested that the Omicron variant may cause less severe disease than its predecessors, including the Delta. So one of the studies is a retrospective study from the US. It's a database-based study wherein they looked at 14,054 patients during the period between 15th and 24th December 2021, last year, when the Omicron variant first emerged. And the authors described this period as the emergent Omicron cohort. What they did was they compared the outcomes of this cohort, the emergent Omicron cohort, and they compared it with those of 563,000 odd patients who developed COVID during the non-Omicron period, wherein the Delta variant and other variants were the predominant strains. They did propensity score matching to adjust for difference in demographic characteristics, socioeconomic status, comorbidities, and vaccination status. They analyzed 4 important things between patients who were in the Omicron period and those who were in the pre-Omicron period. They looked at the incidence of hospitalization, ICU admission, requirement for mechanical ventilation, and the requirement for emergency department visits. So they did all this within a 3-day period from the time of diagnosis of SARS-CoV-2 infection. So when they looked at this in detail, they found that the emergent Omicron cohort had significantly lower rates of emergency department visits, reduced number of hospitalizations, reduced requirement for ICU, and also for mechanical ventilation. So this reduced risk included all age groups, including the pediatric population. So this study suggested that during the 10-day period, which they studied in December last year, during this period when Omicron emerged as the dominant strain, the disease severity appeared to be significantly lower compared to the period when the Delta strain was dominant. So this is some indirect evidence to suggest that the Omicron variant may indeed cause less severe illness, requiring less emergency department visits, hospitalization, ICU care, as well as requirement for mechanical ventilation. A similar study was conducted in South Africa as well, wherein they studied patients during the period when Omicron first emerged. and compared it with the previous 3 waves that they had, the first 3 waves, which included the original strain, the beta variant, and the delta variant. And they found that the rate of hospital admission was significantly lower during the Omicron wave or presumed Omicron wave compared to the first 3 waves. It was 41.3% versus 69%. So there seemed to be a substantial reduction with the emergence of Omicron. The affected population was younger with more female patients during the Omicron wave or the presumed Omicron wave. The incidence of respiratory symptoms was lower with the emergence of Omicron compared to the previous waves. The requirement for oxygen therapy was also lower with the emergence of Omicron, as was the requirement for mechanical ventilation, and the hospital mortality they also found to be lower with the emergence of Omicron compared to the previous waves. So this again was some indirect evidence that Omicron itself may be less severe with less requirement for hospitalization, ICU admission, and perhaps lower mortality as well. The third study was based on the clinical severity of Omicron infection assessed using S-gene target failure, which we mentioned previously. The failure of the S-gene target is on RT-PCR is a method by which you identify, at least initially, the possibility of Omicron. So in this study, they classified infections as S-gene target failure or non-S-gene target failure types, that is Omicron versus non-Omicron. And on multivariable regression models, they compared the symptom severity with the S-gene target failure versus non-S-gene target failure infected patients, which is essentially Omicron versus non-Omicron. And they found that in patients who had S-gene target failure, they were less likely to require hospitalization compared to patients who had non-S-gene target failure. Among patients who required the hospitalization, the severity was similar between the two cohorts. And they also found that overall, S-gene target failure infected patients experienced less severe disease compared to Delta variants. So this study was more focused on Omicron by looking at the S-gene target failure. And they also came up with similar findings suggesting that the severity is less and the requirement for hospitalization may also be less with Omicron. So that's the first kind of information we have on the degree of severity with Omicron. It certainly appears to be lower, but if you consider the sheer number of patients who've been affected, even a small percentage of patients getting severe illness would, of course, push healthcare systems to the very limit.
That's correct. I guess that's the main challenge with this way, where the sheer number are so high that if you see the proportion of patients, the total number of infections reach more than 50,000, you will still get 200 to 300 patients in the intensive care unit in one small city or one state, which is clearly it's impossible to deal with. And that's what we are seeing currently in New South Wales, that the total number of cases per day, when they reach almost 45,000 or 50,000, the hospital admissions increase tremendously. And that significantly puts a lot of stress on the healthcare system. So I think this variant cannot be ignored purely because of that reason, although it seems to be less severe. And also there are other factors that need to be considered and put in the context, because the patients who get this disease, whether they are immunocompromised, whether they have other comorbidities like COPD, whether they have any underlying health condition, which will obviously make them to come to hospital with this variant. And that's clearly what we have seen so far in last few weeks, that patients who are coming to hospital or intensive care unit, they're coming for non-COVID or non-respiratory related problems with COVID positive diagnosis. For example, COVID positive patient coming with DKA, or COVID positive patient coming with non-STEMI. And those admissions are also now increasing in the hospitals and in the intensive care unit. So when the sheer number of cases are so high in the community that almost every single patient is already infected in the community, it puts significant risk to healthcare workers, because then obviously then healthcare workers get sick and they also get affected. So that's the kind of main challenge with the sheer number of cases. Now, in terms of what are the potential treatments, that's also created a lot of controversy. And one of the challenges that I'm facing at the moment is we are using the same template of treatment that we did with the Delta variant. And obviously that was based on the robust trials like Recovery, Remap-Cap, which told us which agents are safe to use, which agents will help us with mortality. But with this Omicron variant, we do not have any data, and we are using the exact template of treatment, what we practice with the Delta wave, and we are trying to replicate the same treatment template for the Omicron cases. And we don't know whether that's still going to be the case moving forward. So, Dr. Chacko, what are some of the studies or some of the treatment options that we have to deal with this new wave?
One of the problems with the diagnosis of Omicron is that, gene sequencing will take time, and you really can't wait for the confirmation of the specific strain involved before you commence treatment. And this has been a problem because we were used to the treating patients with monoclonal antibodies, casirivimab, imdevimab combination for the Delta variant, which seemed to be very effective. Right now, there are many patients who come seriously ill, and of course, you can't wait for them to get confirmed. Even the S-gene target failure diagnostic modality is not immediately available to many. So our practice has been, generally speaking, to use monoclonal antibodies in patients who come early in the course of the disease, like we used to do with the Delta variant. However, having said that, the susceptibility of the Omicron variant to the currently used monoclonal antibodies appears to be poor. In fact, the manufacturers themselves have come up with the suggestion that it may not be effective. However, two new monoclonal antibodies, sotrovimab and DXP604, are currently undergoing investigation. Of this, sotrovimab may be effective against Omicron, and there has been studies that are going on to assess how much would be a good dose. And in fact, the dose required to prevent binding of the SARS-CoV-2 virus to ACE receptors, that's the way it works, may be much higher compared to the Delta variant or other variants. It may be, in fact, up to 3 times as high. So the current monoclonal antibodies, including the casirivimab, imdevimab combination or the Regent-CoV, may not, in fact, be effective against Omicron. You need to look elsewhere, and sotrovimab may hold promise, particularly in a high dose, although we do not have confirmatory studies as yet. Antiviral drugs, on the other hand, are expected to retain their efficacy against whatever variant, including Omicron. So remdesivir obviously has been established to be efficacious with other strains. You would expect it to be efficacious against Omicron as well. In addition, 2 new antiviral drugs, which are taken orally, molnupiravir and Paxlovid. Paxlovid is a combination of 2 drugs, nirmatrelvir, ritonavir combination. So these antiviral drugs have already been tested, and there have been initial reports released by the manufacturers of these drugs. In a phase 3 study, molnupiravir reduced the risk of hospitalization by nearly 50% compared to placebo in mild to moderate COVID-19. And Paxlovid, in a phase 2 to 3 trial, they evaluated more than 2,000 patients with COVID-19, which suggested that Paxlovid significantly reduced the risk of hospitalization and all-cause mortality by nearly 89% compared to placebo among high-risk adult patients if administered within the first days of symptoms. So these drugs they will probably be effective against the Omicron variant as well, although we do not have studies which have specifically tested it against Omicron variant. So these are possible options in terms of antiviral medication in early disease.
Thanks, Dr. Chacko. So I guess that's been quite the challenge dealing with these new cases now. As you mentioned, we don't have the exact diagnosis of whether the patient has Omicron variant or patient has got a Delta variant. And then we are giving everyone tocilizumab or baricitinib at the moment when they deteriorate significantly. And challenge with that approach is sometimes if those monoclonal antibodies are not going to be useful, they can be actually very harmful in that particular subset of patients. So I guess at the moment we are treating pretty much blindly without any major substantial evidence. And one of the challenge is to actually know whether the patient has got Omicron variant or whether the patient has got Delta variant. And you can't delay the treatment. That's true. But at the same time, we don't know whether we are causing more harm than the benefit at the moment. Also, we are using steroids quite significantly, and we are following the dexamethasone, which is shown by the recovery. Hope we will get the more data soon, whether we need to use steroids for almost 10 days in every single patient with this variant. And again, that's something that we need to see, especially with the antiviral. Some of the data which is coming quite promising, I must say, especially with the Paxlovid and the Soturimab. So currently in Australia, we are trialing out here whether patients who are diagnosed with COVID-19 in the first 5 days, whether giving Soturimab reduces the hospitalization. So hopefully, if that's the case, then moving forward, administering Soturimab might actually reduce the hospitalization and take off the pressure from the healthcare system significantly. Having said that, the only challenge with Soturimab is at the moment is administered intravenously. So unfortunately, the patient has to come to hospital to get the intravenous infusion. And that's why I think the Paxlovid has been more promising, because it's taken as a tablet at home. And obviously it has been FDA approved, but it's not widely available across the globe at the moment due to the shortages. So hopefully, as we move through this pandemic with this exciting research, I think we should be able to contain the number of hospital admissions and patient deaths. Now, moving on to the next segment of this podcast is about the vaccine efficacy. And I think there are a lot of questions have been asked around which vaccines are still effective and protective against Omicron variant. How many doses of any vaccine are actually sufficient? And how frequently do we need to take boosters in order to stop getting infected with COVID-19? So, Dr. Chacko, can you please share some of the data that is available around the vaccine efficacy with Omicron variant?
Yes, there is in fact not much data in that regard, I must admit, although there have been a few studies that have specifically asked this question as to whether the existing vaccines are indeed effective or not. One of the studies from South Africa, they tested the efficacy of 2 doses of the Pfizer vaccine in preventing hospitalization during the presumed Omicron period between 15 November and 7th December in South Africa. So this was compared to the period during which the Delta variant was predominant. So the Omicron period compared to the Delta variant with 2 doses of the Pfizer vaccine. That's how they compared it. And when they looked at it, they found that during the Omicron period, vaccine efficacy at preventing hospitalization was only 70% compared to 93% during the period when they had the Delta variant. So it was significantly lower at 70 versus 93% with Omicron. Although the level of protection was lower, the vaccine still appeared to be effective in reducing hospitalization among infected patients during the period when they were presumed to have the Omicron variant as the major strain. So this is indirect evidence as well. But what it adds to in terms of the knowledge we have about vaccine efficacy in Omicron is that with 2 doses of Pfizer, you may still have a significant degree of protection against severe disease and hospitalization, although it may not be as effective as with, say, the Delta variant. Another study, neutralization of Omicron infected cells in serum samples from participants who had 2 doses of Pfizer vaccine was compared with individuals who had 3 doses. So it is a comparison of 2 versus 3 doses with in vitro neutralization of Omicron infected cells. And they found in this study that 3 doses led to a better neutralization of the wild type virus and beta, delta, and Omicron variants compared to the receipt of 2 doses alone. The efficacy of neutralization against Omicron was higher with 3 compared to 2 doses. However, the neutralizing effect was lower with Omicron compared to the Delta variant, even with 3 doses. So here again, it seemed to suggest that the efficacy of the Pfizer vaccine may not be as effective as it is with the previous variants. And there has been a study with the use of the AstraZeneca vaccine, which is of interest to us in India because by and large, that's what most of us have taken so far. And in fact, the government has come up with the policy of the 3rd or the booster dose as well in the last few days. So when they looked at the neutralization antibody titers against Omicron after a booster dose of the AstraZeneca vaccine and compared it to the antibody titers in subjects who had recovered from COVID-19 with the original strains, alpha, beta, and delta variants, they found that the neutralization titers against Omicron after 1 month of the booster dose were similar to titers against delta variant after the 2 doses. So a booster dose, it suggests, of AstraZeneca vaccine may build up antibody titers to nearly as high as those against the Delta variant after 2 doses. So that holds some promise. As I mentioned, most of us here in India have taken the AstraZeneca vaccine, and it might offer some degree of protection with a booster dose, which is actually currently happening in India.
Yeah, no, that's correct. I guess what we have seen so far in New South Wales is we are still seeing some of the patients who are double vaccinated coming with severe illness in ICU. And that's why it's important to have the third dose, whether you have received AstraZeneca vaccine or Pfizer vaccine or Moderna vaccine. It seems that there have been some signal that the Moderna vaccine seems to be much better form for Omicron compared to even Pfizer vaccine. But clearly the booster seems to be the way to go in order to tackle this pandemic. Now, the real question is how frequently are you going to take booster? And clearly there is no consensus at the moment. Israel has moved towards taking the fourth dose, especially amongst the high-risk population and the healthcare workers in order to tackle this new pandemic wave. Because in Israel, the study has probably shown that even with the third dose of Pfizer booster, the immunity is only probably 30% and it wanes after 3 to 4 months. So they are moving towards 4 doses of the vaccine. And that's really concerning for me because that means practically impossible to get your entire population vaccinated with probably 3 doses or 4 doses of boosters. Because even to get 2 doses vaccination amongst 80 to 90% population was quite challenging. And Australia has done it. They did an amazing job by getting 90% population vaccinated. But getting the third booster dose in 90% population is going to be a major public health challenge. So I guess the data is promising, but I think the practicalities of the implications will be quite challenging. Now, moving forward to the last part of the segment is about the social aspects of this whole pandemic, and especially with the fourth wave of Omicron. It has again brought to the surface some of the underlying challenges in the healthcare settings that we were probably aware of before, but we didn't act on it. And somehow it's almost counterintuitive to me that we did not learn our lessons from our first wave or second wave experiences, especially with the Delta wave. And it seems like every time we face the new wave, our preparation seems to be lagging behind, or it's lacking in multiple aspects. The key aspects of this third wave that I've observed so far in last 3 to 4 weeks is significant burnout and emotional drain of the staff members in healthcare settings across multiple hospitals. And that's partly because obviously people are just fed up of working with the PPEs. And also when the healthcare workers are getting infected with COVID-19, that clearly affects their morale and motivation to continue to work in intensive care. So this pandemic has clearly tested the emotional resilience of healthcare workers, especially in the intensive care settings. Also, we have witnessed the strain that this variant can put on the healthcare segment of especially the testings. And that we clearly witness in New South Wales, where testing sites were flooded with patients who are waiting to get tested. And there was a lot of errors in testing reporting. And then the lines were huge. The results were not given in a day or two. So there was significant delay in getting test results. And now to the extent that we have changed our testing requirements to just to do rapid antigen tests and not to do a PCR. Now, the consequence of that is there is significant underreporting of the cases, and the numbers that we are seeing now are clearly just the tip of the iceberg. The problem with the rapid antigen test, though, many people are reporting that they do 1 or 2 rapid antigen tests and they are negative, but they're still symptomatic. And then when they go and do the PCR test, then that PCR turns to be positive. And because the message is not to do PCR tests and then just do a rapid antigen test, a lot of people are not getting tested on time. In that period, obviously, they're transmitting the infection to vulnerable population. And that has been quite a challenge to deal with. And it might be the way for the future where it becomes like another flu or common cold. You don't get tested until you become symptomatic. And if you are positive, you take all the precautions like wearing the mask, hand sanitization, and stay away from the vulnerable population. And it might become the part of our life, at least next year or two, that we have to deal with COVID. The second way, we created separate COVID ICUs and non-COVID ICUs. I guess moving forward, when the majority of the population is actually infected with SARS-CoV-2, it's going to be practically impossible to create those separate ICUs. And that means all healthcare workers might have to just wear full PPE throughout their shift because majority of the population will be COVID positive, and majority of the patients coming through the hospital doors are going to be positive. And last but not the least challenge is about the elective surgeries. In order to reduce the burden of ICU admissions, last way we canceled most of the elective surgeries. Having said that, that has created a significant backlog in the community. A lot of the surgical training has been impacted. So it has got a lot of ramifications, the way we respond to this pandemic. And clearly, it's not sustainable way of dealing with the pandemic. So obviously, this whole fourth wave has posed now a new set of challenges to both healthcare administrators and also the frontline healthcare workers, which are quite fascinating, but at the same time, it's quite challenging to deal with. So, Dr. Chacko, any final thoughts before we wrap up?
You mentioned about staff getting infected and the staff morale being down. In fact, I think that is probably a global phenomenon. Many of our own staff members, including nurses, doctors, have also been affected. And they are in quarantine as well. So that depletes the workforce as well. So that's been a universal problem right through the waves that we have seen one after the other. The other thing is, of course, we've been reasonably okay in that we haven't had too many severely ill patients who need ICU admission in the last couple of weeks. Hopefully it will remain so in the future as well, but it's very hard to tell as to which way this wave is going to take us. Only time and time alone will tell. And we don't have enough information about Omicron, particularly in terms of, as you mentioned, whether we should handle it in a different way in terms of the therapeutic modalities. There is very limited information available at this point of time. Hopefully, there will be more research directed towards it in quick time so that we can actually modify the approach if required. And the question of vaccines, most of the leading vaccine makers say they can come up with a tweaked vaccine in 90 days or so for the Omicron variant. But that's something we need to look at. It is possible. It is maybe quite likely that the current wave may subside sooner than 90 days. So that's very good, not a problem. But hand in hand with that, I hope the manufacturers also renew their efforts to come up with a modified version of the vaccine which will be more protective against Omicron.
Yeah, that's correct. So obviously, there are a lot of things to think about, and there's a lot of research needs to happen in order to deal with this pandemic. And I think this has been the highlight of this whole pandemic, where it has shown the way that entire research and scientific community has responded to this challenge of producing the evidence in a very short period of time and adapting to the challenges that this COVID virus has thrown at us. So I guess overall, I'm hopeful that we will get over this hump again and we will have another bright start for 2022. So thanks, Dr. Chacko. So thanks all the listeners for joining us, and we'll come up with another exciting critical care controversy in next week. Till then, stay safe and goodbye.
Thanks, Swapnil. Thanks everyone for listening. Till we meet next time. Goodbye.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.